This video is to show the importance of the adrenal vein and the adrenal vein anatomy during the performance of a PARTO or a BRTO. The normal anatomy is seen in almost 94% of cases, but variations are known. This normal anatomy would include the left inferior phrenic vein or the LIPV, which has two drainage pathways. One is a transverse segment which opens directly into the IVC, and then you have a vertical segment. This vertical segment drains into the left adrenal vein or the LAV, and which in turn drains into the left renal vein. And this is the diagrammatic representation, again showing the transverse segment of the left inferior phrenic vein, which drains into the IVC, and the vertical segment, which drains into the left adrenal vein, which then in turn drains into the left renal vein. Variant anatomy, however, is known, and one important variant is where the left inferior phrenic vein drains directly into the left renal vein instead of draining into the left adrenal vein. This is the diagram showing the variant anatomy where the LIPV will drain into the renal vein instead of the adrenal vein. At times, rarer variant anatomies may be known, one of which includes the LIPV draining into the left gonadal vein. Again, the diagrammatic representation showing a rare variant where the LIPV drains into the gonadal vein instead of the adrenal vein. So, the gastrorenal shunt is nothing but the left inferior phrenic vein. Embryonically, the LIPV has communications with the left gastric vein and in turn with the portal vein. In fact, in 26% of patients without liver cirrhosis or without signs of portal hypertension, these connections between the LIPV and the portal vein may sometimes be seen even normally. So, what happens in cases of portal hypertension or patients with liver cirrhosis is that the portal pressure increases. This in turn causes the dilatation of the left gastric vein or the LGV, which leads to opening of the anastomotic channels of the left gastric vein with the LIPV, which in turn causes dilatation of the LIPV, and that is basically the formation of the gastrorenal shunt. Now, if the vertical segment of the LIPV gets opened up, that leads to formation of the gastrorenal shunt, while in rarer cases, it is the transverse segment of the LIPV which gets dilated, which in turn leads to formation of the gastrocaval shunt. So this is again a diagrammatic representation showing how the gastrorenal shunt is formed in patients with liver cirrhosis or portal hypertension. So secondary to portal hypertension, you will have the afferent from a dilated left gastric vein, which in turn will form the varices or the gastric varices, and the efferent will be via the dilated left inferior phrenic vein, which is in turn the gastrorenal shunt, which then joins the left adrenal vein and opens into the left renal vein. So, in turn, anatomically, it is important to know where the narrowest portion of the gastrorenal shunt will form. And invariably, the narrowest portion of the shunt where the plug will be deployed will be at the point of opening of the left inferior phrenic vein into the left adrenal vein or just above it. So here's a diagrammatic representation showing the narrowest portion of the gastrorenal shunt which will be just above the opening of the adrenal vein. The image to the right again showing on CT the narrowest portion of the shunt, and very nicely you can see the adrenal vein just posterior to it with the opening of the left adrenal vein just at the level of the narrowest portion of the shunt. So, because of this anatomy, it is important to consider certain points with respect to the adrenal vein while performing a PARTO or a BRTO. The most important point to consider is that we should avoid an inadvertent cannulation of the left adrenal vein instead of the shunt, which is towards the left inferior phrenic vein. So while advancing the wire, we should make sure that the wire is not directed laterally towards the adrenal vein, but we should be having a straighter course of the wire towards the straight segment, that is towards the gastrorenal shunt or the inferior phrenic vein. In fact, an inadvertent plug deployment into the left adrenal vein can in turn lead to increased adrenal pressures and an adrenal hemorrhage. So there is less data on this, but our group itself had published a paper a couple of years back where an inadvertent cannulation of the adrenal vein during a PARTO with partial deployment of the plug into the adrenal vein resulted in the formation of an adrenal hemorrhage. This was published a couple of years ago, but there is less data on this. Another point to consider is that because there is a close association of the adrenal vein with the inferior phrenic vein, we should be avoiding forceful injection of contrast from the sheath during PARTO placement. So, in fact, while performing PARTO, two things need to be into consideration. A, that the sheath should be parked only in the straight segment, and prior to placement of the plug, in fact, the wire should remain deployed within the sheath for stability of the sheath so that the sheath does not fall back into the adrenal vein. Importantly, forceful injection of contrast from the sheath should be avoided. What this can do is it can lead to increased pressure of the adrenal vein and lead to adrenal rupture. So, the last point with respect to this is that does the placement of the vascular plug eventually affect adrenal function? Slide 20. So, there is very less data on how does a plug placement or deployment affect adrenal function in the long term. There is very poor documentation of this. Now, the narrowest portion of the shunt is ideally just above the level of joining of the adrenal vein, and the plug is ideally deployed across the narrow portion. So while placing the plug and after plug placement, when we do deploy the sclerosant into the gastric varices, we do not know whether a retrograde reflux of the sclerosant into the adrenal vein and into the adrenal gland can cause long-term side effects. The data on this is very, very poorly documented. So again, here is the theoretical implication on adrenal function post-PARTO. Now, secondary to plug deployment, there is a possibility that some sclerosant into the adrenal vein can actually impair adrenal function in the long term, but data on this is missing. So, just a couple of papers. There was a case report published again in the American Journal of Gastroenterology showing that adrenal insufficiency was documented post-PARTO, but this was again on a long-term follow-up, and one odd cases of long-term adrenal insufficiency documented by the Korean group as well. So the key points in this is that understanding the adrenal vein anatomy as well as the relationship of the left inferior phrenic vein and its resultant formation of the gastrorenal shunt is key. Two important points in this. One is that inadvertent cannulation of the left adrenal vein should be avoided during the procedure. The wire should be always parked in the straight segment, that is towards the LIPV or the shunt and not towards the adrenal vein. Enough purchase of the wire should be taken. Also, straight course of the sheath. Maintain the sheath in a straighter course at all times. In fact, the wire should be parked within the sheath before plug deployment so that the sheath does not fall backwards or into the adrenal vein laterally. And lastly, forceful injections of contrast should be avoided because then that in turn can cause retrograde reflux of contrast or the sclerosant into the adrenal vein and can cause adrenal injury.